The most attractive and severe illness that affect the patients, which is the acute or fulminant hepatic failure. Fulminant hepatic failure is a clinical syndrome of sudden, severe impairment of the liver function, which is important is in a previously healthy person, to differentiate it from the acute on top of chronic parenchymatous liver disease. My voice is clear?
Yes.
Yeah. No need for the microphone. Encephalopathy, severe coagulopathy, as well as other metabolic abnormalities are usually present. These are one of the salient features for fulminant hepatic failure. If we look to the causes and the pathogenesis of fulminant hepatic or acute liver failure, it is divided into many items. The infections like virus hepatitis and herpes, drugs, overdosage of paracetamol, although paracetamol is considered to be the safest analgesia in chronic liver disease, but in a small dose. So the overdosage, which we mean more than 8 grams per day, so 16 tablets, and this is impossible. So if we give analgesia for the chronic liver disease, it is usually 1, 2, or 3 tablets, so maximum 1.5 grams. So we are below the overdose that is deleterious to the patient. Hallucine, isoniazid, antidepressant, and the famous drugs to be used, the non-steroidal anti-inflammatory drugs. Mushroom poisoning is not here. It is common in France because it is used as in a wide-scale manner, and the fungus infection may be the cause of this toxicity. Ischemia, the ischemic hepatitis, surgical shock, acute bad Chiari, some metabolic diseases like Wilson disease, fatty liver of pregnancy, and Ray's syndrome that is to be present in some children with overdosage of salicylates. Miscellaneous severe bacterial infections and heat stroke. Mushroom poisoning is common in France in areas where unusual fungi are gathered and eaten. At full-term, pregnant women may develop fulminant necrosis due to eclampsia. The patient previously well from the start presented with nausea, vomiting, malaise, jaundice, that follow, and then features of hepatic encephalopathy. If you look to these features, it is usually like anything: nausea, vomiting, any gastro-upper GI disease may lead to that, but rapidly the patient go to coma that may develop rapidly within a few days. In the early stage, jaundice bears a little relation to the neuropsychiatric changes, which starts early. So encephalopathy starts early in acute hepatic failure rather than the appearance of deep jaundice or jaundice from the start. So if you didn't find deep jaundice, does not exclude acute hepatic failure. So jaundice doesn't correlate with the severity of the condition, at least in the early cases, in the early of the case. In the early stages, jaundice bears a little relation to the neuropsychiatric changes. Later, jaundice deepens because the liver size is extremely shrunk. Vomiting is common, but abdominal pain is rare. If we compare acute fulminant hepatitis to acute pancreatitis, pain in acute pancreatitis is severe and has a characteristic features, but pain in acute fulminant hepatic failure is not one of the salient features of fulminant hepatitis. Tachycardia, hypotension, hyperventilation, fever are later features. Common complication of fulminant hepatic failure includes the infection, hemodynamic disturbances, and the cerebral edema, which we will speak about later on. When you find a patient with suspected to be acute liver failure, these signs predict the development of acute liver failure or hepatic failure. If the bilirubin rises shooting up to more than 20, change in the conscious level, hyperventilation, marked hypoglycemia, decrease in the albumin, INR prolongation, decreases in the coagulation, decrease in the liver span, and along with decline in the transaminase first and then rise, then increase fetal bilirubin and the decrease in the serum albumin. So the liver functions, which we mean that the liver functions include the serum bilirubin, serum albumin, and the prothrombin. The enzymes are not considered to be one of these. If you find a patient with acute hepatic failure or suspected to be acute hepatic failure, you have to make some of these investigations in the form of hematology. The aim of this to be sure the diagnosis is acute hepatic failure. The second, to know which cause you can meet with, to be easy to treat if you are going to treat. So we are going to make some of these investigations. The hematology, blood picture, including the hemoglobin, platelet, YPCs, and the prothrombin. Biochemical, the blood sugar, serum bilirubin, enzymes, albumin, serum blood urea, creatinine, and the creatinine is the most accurate than blood urea. Electrolytes, potassium and sodium, bicarbonate, chloride, calcium, alkaline phosphatase, and serum amylase. Because serum amylase also increases in the acute hepatic failure, but does not reach the utmost level of acute, like acute pancreatitis. The microbiology and the virology for the cause, either viral, hepatitis B, C, A, serum delta, which is present usually with hepatitis B, blood culture, aerobic and anaerobic, sputum and urine with stool cultures, and you have to store some of the serum for the other investigations you may need. EEG, ECG, X-ray of the chest, fluid intake and the output, because overloading of the patient may be deleterious to his condition. Blood gases, blood alcohol, for fear of the drug toxicity, because here in Egypt the alcohol is not a cause of hepatic disorder, because we are not alcohol consumers. The other drugs that I mentioned before, the urine electrolytes, plasma fibrinogen degradation products, because in acute hepatic failure, DIC or disseminated intravascular coagulation is one of the features, and you know that the disseminated intravascular coagulation is associated with marked decrease in the fibrinogen and the platelets, which we will find later. In hepatic scanning by the radiology. Falling or failing platelet count may reflect disseminated intravascular coagulation, as I said before. Low albumin reflect a poor prognosis. Transaminases are of little prognostic criteria. Levels tend to fall as the patient condition worsens. Hepatic encephalopathy, the pathogenesis, which is one of the main salient features of acute hepatic failure. Hepatic encephalopathy, the pathogenesis of hepatic encephalopathy is a multifactorial and centers on failure of the liver to remove the toxic substances, which is usually or mainly nitrogenous compounds. Also, many other associated pathogenesis like hypoglycemia, brain edema, the false transmitters, the electrolyte disturbance, the acidosis which may occur. In these conditions we may find either respiratory alkalosis or acidosis according to which type affected. Sometimes we find metabolic acidosis due to the degradation and the necrosis of the tissues. The onset of encephalopathy is often sudden and may precede jaundice with agitation, changes in the personality, delusions, and restlessness. The grades of encephalopathy, they are classified into 4 grades. Grade 1, minor disturbance of the consciousness or a motor function. Grade 2, the patient is drowsy, or grade 2, the patient is drowsy but responsive to command. If you ask the patient to reply anything, he can reply. Grade 3, stuporous, more than drowsy, but the response is to pain. If you squeeze the skin or the ear pin or something like that, the patient may be alert. And the grade 4, there is unresponsiveness to pain. Seizure may appear at any grade of these 4 grades. There are many aggravating factors like gastrointestinal bleeding, hypovolemia, electrolyte disturbance in the form of potassium depletion, which is common because the patient is hypoglycemic, and we will give the patient a big dose of glucose, and you know that the glucose leads to intracellular shift of the potassium, so the patient is usually hypokalemic. Uremia, infection, constipation, sedatives. As we said before, the patient may be agitated. Sometimes we can give, some doctors may give some sedatives to the patient, and these sedations may be responsible for aggravating the condition of the patient. And if the patient took high protein infusions. Cerebral edema, it is one of the manifestations of acute hepatic failure, and it is one of the deleterious conditions. The cause is probably multifactorial, either vasogenic due to vasodilatation or a cytotoxic due to the drugs. Clinically, there is manifestation of increased intracranial pressure. It is suggested by high systolic pressure and increase in the muscle tone and myoclonus, and what is called the decerebrate rigidity. There is hyperpronation of the arms, the patient hyperpronated arms, and the marked extension of the legs. This is called the decerebrate posturing or decerebrate rigidity. And there is this conjugate eye skewed position of the eye may be seen. Cerebral edema may lead to brainstem herniation. Cerebral edema is considered to be one of the most dreadful conditions. It is responsible for about 80% of deaths in these patients. And due to the acute condition of the short time of the condition, there is no papilledema. It is not a manifestation in cases of cerebral edema due to hepatic failure, because there is a short duration. It takes only few days. The third condition, which is one of the characteristic or the salient feature of hepatic failure, is the coagulopathy, not only due to factor deficiency but also enhanced fibrinolytic activities, most likely caused by the intravascular coagulation and the disseminated intravascular coagulopathy. Platelet count may fall due to increased consumption in this intravascular coagulation, or reduced production, or the platelet function is also abnormal, which is called the cytopenia. The resulting coagulopathy predisposed to bleeding. The prothrombin time is the most widely used test to assess the coagulation, and the prothrombin or INR is considered to be one of the most important things in the prognosis of the patient, and it is considered one of the famous conditions to elicit or to decide the transplantation for this patient. We will speak just few minutes. Coagulopathy used to be the leading cause of death before the era of liver transplant. Low level of coagulation factors, the vitamin K dependent factors 2, 5, 7, and 9. High level of factor 8. Milder coagulopathy may be caused by disturbance of the vitamin K absorption associated and aggravated by thrombocytopenia and thrombocytosine. So the bleeding tendency is related to these defects. The hypoglycemia, hypokalemia, metabolic changes, these are the metabolic changes who the patient are prone to be faced. Hypoglycemia is found in up to 40% of the patient with fulminant hepatic failure, and they may be persistent and intractable at sometimes, and they can cause rapid neurologic deterioration, and is considered to be one of the cause for the seizures, which I said before. Hypokalemia is common and due to in part to urinary loss with inadequate replacement and the high glucose feeding that lead to the intracellular shift. Serum sodium level tended to be low and falling markedly in the terminal stages. Acidosis, the acid-base changes are common. Respiratory alkalosis due to the overbreathing, which starts early. Sometimes the respiratory acidosis, and this is due to the elevated intracranial pressure and the respiratory center depression and the pulmonary complication. Lactic acidosis also develops in about half of the patient. It is related to inadequate tissue perfusion due to hypotension and hypoxemia. Infection, the acute hepatic failure patient is prone to infection. 90% of patients with acute liver failure have clinical or bacteriological evidence of infection. So we do cultures from any fluid during the investigation. The majority of infections are mainly respiratory, related to the poor host defense with impaired Kupffer cell and the polymorph function and the defective complement system. In addition to the aspiration pneumonia where the patient, any comatose patient, is prone to aspiration pneumonia and it invites infection. So the pulmonary infection is one of the commonest sites for infection. Fulminant hepatic failure may be associated with fever and may be not associated with fever. May aggravate encephalopathy. Endotoxemia may increase the liver injury. Gram-negative organism or Staph aureus are the commonest organism by the cultures. Remember, the only sign of infection may be deterioration of the liver function and the encephalopathy. Sometimes the patient is afebrile, no fever, and this is one of the bad prognostic criteria, because the fever is considered to be a quarrel between the bacteria and the host mechanism of the patient, and if there is fever, this means there is a response from the immune system of the patient, and this is good. The renal complication, the second site for infection is the kidney. The renal infection is considered to be the second cause of infection after the pulmonary. In addition to the hepatorenal affection, and the hepatorenal syndrome develops in up to 50 or 55% with or without acute tubular necrosis. The serum creatinine is preferred than the blood urea, because the blood urea may rise due to the tissue perfusion defect and the tissue necrosis due to the hypotension in the time that the kidney is still good. So you might find the high blood urea with normal creatinine, and this means that the kidney function is still good. After that, if the serum creatinine deteriorates, this means that we are going to face a case of renal affection, renal failure, and renal hepatorenal syndrome. Sepsis, endotoxemia, bleeding, and the hypotension contribute to the acute kidney insult. Pathorenal syndrome characterized by oliguria or anuria in the late stage. It is essential to correct the hypovolemia to maintain renal perfusion. To maintain the blood pressure, you give dopamine, then furosemide as a diuretic, mannitol. If we need hemodialysis or hemoperfusion, it is a late condition. Hypotension is a feature of liver failure. It is associated with low peripheral vascular resistance. Infusion of N-acetylcysteine improves oxygen delivery to the tissues, and this is important. Cardiac arrhythmias of any type may be present. Depression of the brainstem function eventually lead to circulatory failure. Pulmonary complication and aspiration of the gastric content or blood atelectasis, infection, respiratory depression, all are complications that may affect the pulmonary system. There may be a pulmonary edema, adult respiratory distress syndrome, usually refractory to treatment. X-ray chest show abnormalities in over half of the patient. Acute pancreatitis and hemorrhagic or necrotizing pancreatitis is a frequent in patient dying with fulminant hepatic failure. Serum amylase levels are raised in about 1/3 of cases. When you are facing a case like that, you have to put a strategy for the treatment, or how can you treat or manage such a case. The essentials of the management: diagnosis of the cause of the liver injury and the associated complications, then skilled intensive care to minimize the aggravating factors and the complications until liver function recovers, or you are preparing the patient for the transplant, then the liver transplant. Blood sugar checked every 3 to 6 months, 6 hours. I said before that sometimes the blood sugar is failing to resistant conditions or resistant to be elevated. So we are going to check the blood sugar every 3 hours, avoid the sedatives, limit the fluid to 60% because we are aiming to maintain the patient on the dehydrated side, maintain normal blood pressure and the CVB, fluids in the form of dextrose 10 to 20% with 3 millimole per kilo per 20 hour of the potassium, because I said before that hypokalemia is a feature due to the high glucose intake. So at the same time we put 3 millimole per kilo per 24-hour potassium to guard against the hypoglycemia, the hypokalemia induced by the glucose infusion. Then monitor the urine output and the fluid loss. This chart summarizes the steps that we are going to deal with. The portosystemic encephalopathy, no protein, phosphate enema, no sedation, and lactulose, in addition to the main items to be given for the patient. The cerebral edema, you add intravenous mannitol. For the hypoglycemia, we give glucose 150% glucose if the blood glucose falls below 60 milligram per deciliter, up to 3 liters, 10% glucose per 24 hour. Correct the hypoglycemia as I said before. Check the blood glucose hourly if you are going to give glucose, and the 6 hourly if there is no marked hypoglycemia. You correct the blood calcium or the serum calcium, giving 10% calcium gluconate intravenously. Renal failure, if you are reaching a case of renal failure, either hemofiltration or dialysis, the respiratory failure, intubation, and ventilators, the patient is put on ventilators, oxygen, and they maintain the normal blood gases. Hypotension, we give dopamine to maintain the normal blood pressure to perfuse the different tissues. Infection, frequent cultures, and the antibiotic prophylaxis. Bleeding, you know that in stressful conditions, the patient is subjected to upper GI bleeding. So you have to give prophylactic proton pump inhibitors, fresh frozen plasma and the platelet to guard against the coagulopathy. Then some cases which does not respond, it needs artificial liver support to provide support until the native liver recovers its function spontaneously or until a donor liver is available. The use of columns or membrane as a hemofiltration would allow removal of the toxic metabolic like charcoal hemoperfusion. It is not available in our unit. Extracorporeal liver assistance. The hepatoblast transplantation, sometimes capable of synthesis and detoxification, proved by improvement in the encephalopathy, coagulopathy, and the ammonia level. Severe serves as a bridge to liver transplant. And these conditions, it needs a team between the hepatologist and the surgeon, because the outcome of these patients by the medical treatment is not favorable. So the transplant is prepared in every case of acute hepatic failure if there is a specific or specified center for the hepatic transplant. For the criteria for liver transplant in a fulminant hepatic failure, the acetaminophen induced, because the drug-induced hepatic failure in Europe is considered to be one of the major causes. So, if acetaminophen induced, the pH is considered to be one of the major criteria for deciding a hepatic transplant. If the pH more than 7.3, irrespective of the grade of encephalopathy, you give the decision of transplant, or the prothrombin time more than 100 seconds, or serum creatinine more than 7 mg/cent in patient with grade 3 or grade 4. While the non-acetaminophen fulminant hepatic failure, prothrombin time more than 100, irrespective of the grade of encephalopathy, itself is considered to be one of the indications for the hepatic transplant. Or any of the three of these, the age below 10 or above 40, the etiology of non-A, non-B, hepatitis, hallucin, hepatitis, idiosyncrasy, drugs, duration of jaundice before the onset of encephalopathy more than 7 days, prothrombin time more than 50 seconds, or the serum bilirubin more than 20 mg/cent. And I think it is. Thank you.